Going on now? Okay. Hello, everybody. Um, let's see if anybody is on here now for us. Great. Okay. So this feels a bit like deja vu because last night George got really busy, so he couldn't make it. So today he's definitely on, and he's just phoned me to say he will be here any minute. So that's good. See what's happening here. Okay, I'm just waiting for George to come on. So many questions to answer as well, which is great. Okay, this is the worst bit. So here we are connecting now. Oh, at last, George, at last.
Long last, Zita. Long last.
I know it was very difficult yesterday because you were very busy, so I totally understand. But we've had so many questions, so it'll be good to sort of answer them if we can. Oh no, not again, George. You're frozen. Okay, George. No. George is frozen in the corner there, so I'm going to have to start answering some of the questions that have come through. He's left. He's probably going to join again. And it's quite interesting with some of these questions because some of them are really in depth and there's no medical background or history. So they're going to be quite hard to answer, but we'll do our best to do that. So let's just see if George reappears again at any moment. Okay. Still waiting. One of the questions that has come through, which I can answer very easily, is I wanted to ask you whether you were still seeing clients from the outside of the UK. I'm from Malta, and yes, we are. We see a lot of clients from outside of the UK, and we see a lot of clients from Malta. So the answer to that is yes, we do. Let me just see if there's any more. Oh, you've joined again. You froze, George, for a minute.
Yes, I don't know why I'm freezing. I don't like the cold.
Oh, is somebody sitting in there with you? Is Victoria with you?
Victoria is here with me.
Oh, good. Okay, I feel confident now.
1 second. Together. Okay.
Okay. So, George, I've had lots and lots of questions, and I've just been saying to the women watching is that some of them are very in depth and they've got no medical history. So hard to do this. Oh my goodness. You back again?
I'm back again.
Okay. So first question. I want to know if there's anything else I can do to improve my IVF. It's my third transfer. I'm 37. I have no children after a successful egg retrieval and 10 embryos, all graded high quality. I've had 2 transfers which have failed. I've tried everything from improving my diet, losing weight, exercise, vitamins. I've had the endometrium test. I don't know what she means by that. I've taken antibiotics. Is there anything? I have no underlying health issues. I have a regular cycle, no PCOS, no alcohol or caffeine. What are the next things that I can do?
Well, what I would do would be to actually do some more investigations. I think that's where testing to see whether there might be immunological causes will come into play. Because everything might be okay. I know, we do have a lot of debate about the immunological issues, but the only time in our bodies something foreign comes in and we don't reject them is in pregnancy. So if anything goes wrong with the process of immune tolerance, which allows you to have the baby, then of course can affect the outcome. So if you've done all of these things, there must be a reason why you're not getting pregnant. And I would do the investigations. We do have 2 levels of tests. Level 1 test, where we're asking, is there any simple medical reason why you're not getting pregnant? or level 2 tests where we interrogate the immune system more robustly, and we ask the questions to see whether there's any underlying issues, and if there are, then we can treat them. The treatment is pretty straightforward, but you need to find out what the problem is in the first place.
Okay. Another question here. I would like to ask you, how can you treat a patient with autoimmune condition lupus in total remission and currently also MTHFR positive? I've had 3 miscarriages in the past before IVF and during IVF. Thank you in advance.
Yeah, there are two issues here. One is the autoimmune condition with lupus, which can be treated. Usually, the simplest treatment for that, if it's been proven to have lupus, would be to consider steroids. And of course, sometimes in lupus, you have increased blood clotting tendency. If you have lupus anticoagulant antibodies, then in that case, you need to add a low dose aspirin and low molecular weight heparin, Glexane or Fragmin. And that's what you need to do for those.
Yeah.
Then the MTHFR, this is the gene implicated in the metabolism of folic acid. So I would check if you have mutation in this gene, then you're not metabolizing folic acid well enough. So one of the steps slows down. When it slows down, there's a damming effect. So the amino acid just before it, homocysteine, begins to build up. If it keeps going up, that can then cause blood clotting tendency, thrombophilia, and that can cause clotting, and that's what can increase the risk of miscarriages, and sometimes even to reduce the chances of having a successful implantation in the first place. So there are treatments for that, but
it's interesting because one of the ladies has just asked quite rightly that steroids aren't being prescribed at the moment because of COVID.
They're not being prescribed at the moment. It's interesting because I have a patient who is involved in treatment for recurrent miscarriage in a teaching hospital in London. I was surprised that they asked her to use steroids. The care policy is not to use steroids. So I told her, well, as long as the professor is the one prescribing it, then that's fine. So she's going to have steroids, even though I'm not the one prescribing it. So, it is a big thing. If you consider that, when Trump had COVID, he was actually given steroids.
Yeah.
Then it's a very interesting area, which, the evidence not to use it, it is, I struggle with it, but that is what the policy is.
Yeah. George has gone again.
Sorry.
Okay. So another one, I'm starting IVF for the first time in 2 weeks. My partner and I were diagnosed with unexplained infertility issues 18 months ago. After all the tests, no issues can be fine with either of us. Is there anything I can do to help my first round to be successful via diet, exercise, etc.? Well, at the clinic, we believe a lot, don't we, in the holistic approach. So
Absolutely.
Certainly for us, it's about nutrition for healthy eggs, healthy sperm, vitamin D, inositol, everything that you can do. Mindset is really important as well. So we look at acupuncture and hypnotherapy. So, the holistic approach, I think, is really, really key. It's her first IVF, round of IVF, don't you think?
I think so. I think you nailed it. And I also think that maybe they should check your thyroid function tests.
Yes.
Just to be sure that that it's not suboptimal, because sometimes you need to optimize the thyroid function in order to optimize the outcome. So these are things you can do, your doctors can do for you. And if there's a need for intervention, I'm sure they should know what to do.
Yeah. Okay. Right. I will be starting a fresh round of IVF in November when my period starts. Injections start in December, egg collection in January. I've been taking Zita, which means Vitafem, but it's quite nice, the name Zita, for a couple of months, which is a multivitamin. And I've ordered inositol. I've noticed it has folic acid in as well as the Vitafem. Am I taking too much? No, it's fine to take both of that. Also, I regularly exercise, running, weight training. I want to know when I should reduce exercising in preparation for IVF. Well, I don't know about you, George, but I think you should stop before IVF, especially if you're doing a lot of weights and running, etc. And I think certainly when you're going through a cycle, you know, and you're stimulating, it's not good to do a lot of aerobic exercise.
Yeah, you know, exercise is good for you, but excess, you do it in excess is not good enough for you. It won't be good for you. The simple reason being that, you know, in terms of implantation and conceiving, you need the blood flow preferably to be going to the pelvis.
Yeah,
And if you're doing very strenuous exercises, then the body will prioritize the muscles, and the blood flow goes to the muscles instead. Well, rather that it went to the pelvis,
yeah,
to improve blood flow in the ovaries, in the lining of the womb, and the rest of it. So, you know, whereas exercise is moderate exercise is okay. Certainly, I wouldn't advise you to continue the strenuous ones. And as a matter of fact, there's a study done that showed divided women into three groups. One group did nothing. The other group just got on with their normal lives, just, you know, just walkings and exercise. The other group went to the gym, I think, twice a week. Very, you know, full-on gym work. And the best outcome was actually people who just got on with their normal lives. So, you know, walking and just being fit. Those that did nothing actually didn't do as well, believe it or not.
yeah.
They were bed rest, and the those that went to the gym didn't do well enough. So,
Yeah, I think as well it is moderation, but I sometimes when you're being stimulated and you've got a lot of follicles, it can be quite painful as well, can't it? You know, to sort of jog and run.
and also run the risk of torsion. So
Yeah,
because the ovary is full of eggs, it's like a bunch of grapes. So if you're doing exercises where you're doing very sharp turns, if they twist, that's one of the most serious gynecological
yeah,
emergencies. So
yeah. Okay,
I wouldn't encourage that.
okay. Just failed my first round of IVF and struggling with secondary infertility. I've lost a tube due to an ectopic last year. Feel like everything we did, nothing went right, but every test and scan leading up to IVF was great. I did ICSI, had one frozen embryo transferred, was not advised, hang on, fresh transfer was not advised to avoid OHSS, hyperstimulation. What can we do next time? We have 3 embryos left. The only thing I can think of is I regularly get UTIs, which are urinary tract infections, and always seem to have low levels of leukocytes. Is this a problem? Any advice would be great.
Yes, if you have UTIs, definitely is better for it to be treated, because even in pregnancy, UTIs are associated with sorry, just keep falling off. It's associated with preterm labor and the rest of it, even premature rupture of membranes. So, you know, UTI should be treated. There's no question about that. And also, if you use it, I assume you're talking about 3 embryos left
Yeah,
frozen. We did some studies here, it must be 3 or 4 years ago now, when we found that the level of progesterone during frozen embryo transfer was a game changer. I couldn't believe it. I looked through the data, our data, as is the West Clinic, and found that, you know, there's a cutoff, more like a cliff. You know, before that, pregnancy rates were low, 20%, 30%, miscarriage rates very high. Above that, 70%, hardly any miscarriages. So we thought, that's interesting. We never knew that. Nobody has ever done any work on that. So we we developed a cutoff point. And I was surprised that when I went to a meeting in Geneva, a professor in Denmark found exactly the same thing as we did, the same cutoff. Some more work has been done to show the value of having good levels of serum progesterone. So I would ask your doctors to maybe look at that, make sure that's adequate. The only way you're getting progesterone is what they're giving you, and if it's not enough, pregnancy rates and outcome is really poor.
Well, that leads into the next question. What role can progesterone play in a cycle? Can progesterone levels drop during treatment? Does high progesterone cause failure? I had 2 embryos of good quality transferred on day 3 with excellent lining on transfer, but ICSI cycle confirmed failed yesterday. I understand there can be multiple reasons why IVF fails. I've had intralipids. I've done 3 months of supplements, done DNA sperm fragmentation prior to the cycle. So just explain what we do with progesterone in a cycle, because we test a lot, don't we?
Yeah, we check every day. Every time you come for monitoring, we check your progesterone levels. Progesterone should only rise after ovulation. If you have raised progesterone before ovulation, what happens is that it accelerates development of the lining. So you may have this beautiful embryo, but it's completely out of sync with the embryo. So you put the embryos back on day 5, but the endometrium is about day 8, because progesterone would accelerate your development. So if it's too high, we would freeze the embryos, and then you come back and we handle it and manage it enough so that we can improve the outcome. And then, of course, but you need progesterone afterwards. And if you don't have enough of it, then there's another problem with it. So progesterone is important. It needs to be low before, but it needs to be adequate afterwards. And the way you manage it is fine. And intralipids, I'm assuming that you did some immune tests, because giving intralipids empirically without any tests, for me, is bad medicine. Simply because, how do you know you're using the right amount of intralipids? Do you need 1? Do you need 2? Do you even need 3? So I'm assuming that your clinic has done all the investigations and think that you require intralipids. And intralipid is not a magic wand. It's only useful if there's a reason to use it.
Another question that's just been asked here is, what about progesterone and FETs, frozen embryo transfers? Because I know you like to test as well, don't you? After
progesterone in frozen embryo transfer is everything.
Is it? Okay, just explain why, George.
Because the studies we did shows that clearly. I remember that evening I was going through all our results because we were checking progesterone. I used the American publications to think, okay, maybe we should have it at this particular level. So we were keeping records of them. So I sat down one day, started looking at the levels relating it to outcome. I was surprised. It was just incredible. I mean, when you discover something, I think, hang on a second, is it really true? All of a sudden, I was about to leave the office at 6. I was there till 9, thinking, no, I need to get to the bottom of this. Yes, progesterone, very important. The work we've done here, the work this professor in Denmark did, and the work done by the IVI group in Spain, all are saying the same thing. Progesterone, the levels are important in FET, in frozen embryo transfer, even more important in frozen embryos than in a fresh cycle. Because in a fresh cycle,
you test, don't you? It's like we do a lot of frozen embryo transfers, because you won't put the embryos back if the progesterone isn't correct. If
it's not correct, we would put them back, but if it's not correct, we will simply optimize it. So
yeah.
What we're doing now is giving more progesterone, so we don't need to check. But ideally, you should check, and if it's not up to the level, your cutoff, then you have to give other forms of progesterone and recheck it after 2 days to make sure you get it to the right level.
Okay, somebody's just asking here, George, if progesterone is too high, can it cause an embryo not to attach or implant?
Very, very, very interesting question, because I did ask that question in Vienna. This group in Spain did the studies, very large studies, thousands, about 2,000 or 3,000. And I said, okay, this is what we found, but is there an upper limit? They said no. In their studies, they didn't see any. There's no upper limit. Okay. So it cannot, from what they say, they're saying that you can't say you have too much of it.
Okay, so what's like, are there different reference ranges? This lady's asking.
No, the reference range is purely the cutoff for weight when it's too low.
Yeah.
For us in the UK, in our clinic, the lab we're using is 50. Yeah. The Europeans use a different units of measurements, but if you work out their measurements to the one we would use, they think it's about 30. But we say 50. The Danish professor says 50, so we're sticking with 50.
Yeah. Okay, but it is. I know it's very important. I know that you
very. One thing we've learned in the last few years is how important the levels of progesterone is if you're having frozen embryo transfer.
Yeah, and I know one of the things for you, George, is you really like to sort of micromanage a cycle, don't you? You sort of like the detail is really important.
Yeah, it's absolutely important. In fact, there's a concept we're developing, time to conception, which I think is very important. I'm trying to see if I can get my colleagues to buy into that, time to conception. What it means is that, people should get pregnant as soon as possible if they're trying to get pregnant. So if you can get pregnant in January, there's no need having the pregnancy in December, because the sooner you have it, then the better, because then it saves you time, it saves you money, it saves you all the emotional turmoil of having cycles that don't work, So what that means for clinicians, therefore, is that when you see a couple in front of you, you're thinking, what is the quickest way for them to achieve this goal? That means you have to do a lot more work, a lot more sort of tweaking. It is tough, we have one of the best results in London. It's not easy. It means you have to work harder. It means you have to do the little things. It may just give you 5% advantage here, 3% there. Altogether, it becomes quite a good percentage of improvement in outcome. So we do micromanage our cycles to make sure that all the tiny things, we tighten all the loopholes and all the loose ends. It's one thing, with people who want to get pregnant, you're going to help them do it and as soon as possible. The longer it takes, the more money it costs. It's more expensive. Then the psychological impact is more. So concept of time to conception should be as short as possible.
Okay. Another question here. I got pregnant in March after coming off the pill, but unfortunately had a miscarriage at 9 weeks. I've had some blood tests and was diagnosed with subclinical hypothyroidism in June. I was told not to try for 2 months. My TSH levels were 5.9, and in September they were down to 1.7 after taking thyroxine. I've been advised to carry on with this dose for the foreseeable future. Me and my husband are both 32 and would like to conceive as soon as possible. We're both healthy. Is there anything you would suggest to help the process? Would you also say we're in a better position to try again, have a healthy pregnancy and a baby? I'm having acupuncture to help with stress, and I have a regular cycle of 28, 29 days.
Of course, the thyroxine levels, the TSH can be reduced quite quickly. Yeah. Here, we definitely wouldn't say don't conceive for 2 months. Why wouldn't you try to conceive for 2 months? You start the thyroxine. You should recheck it in about 3 to 4 weeks. And now that you've got the TSH to 1.7, you're in a far better place in terms of achieving a pregnancy. Because the entire thyroid thing is optimized. So yes, don't wait any longer, please.
Yeah, and I would think as well, if she came to the clinic, it wouldn't be IVF, it would be encouraging her to try everything naturally within a time frame.
Of
because
course.
she can do it. Once her thyroid has come down, she stands a
Yeah.
really, really good
Yeah.
chance. So that's really important. So make sure you're ovulating, make sure you're having lots of sex, and doing absolutely everything you can, because not everybody needs IVF. And it's fine sitting here talking with George, and I know that we are an IVF clinic, but sometimes you can run down that route too quickly when you don't need to. You know, there was obviously something wrong with this lady and it's been corrected. So you just need to have a bit more belief in your body and see what happens. But don't leave it too long, but do the best you can. And we would love to see you, but we don't want to see you. Okay, the next one, George, is any advice on how to deal with a thin endometrial lining, 5 millimeters? I mean, women do get fixated, don't they, on the lining and the triple layers and everything. What is your view of that?
Well, you know, obviously it's important to have a good endometrium. And if you have thin endometrium, I would step back a bit more and say and ask, why is it that you're having it? Have you had a DNC in the past? Have you had any
Well, that's the
uterine?
second part of her question is, my period is now lasting for 1 day and I'm ovulating early, approximately day 11 of the cycle, all after an ERPC 4 months ago.
Oh, good. So that's the thing. That's what I would have asked you. If you've had such an intervention, then a possible reason for the thinness of the endometrium is maybe you have some adhesions, some scar tissue from the ERPC, and you should have hysteroscopy and check if there are any adhesions, then treat the adhesions. And quite often people will then get pregnant. But sometimes you do all this and still there are no adhesions, and still you cannot get the endometrium to thicken. And for me, I give an example. We had a lady who had the first time actually. She was a lady having treatment in Spain some years ago, and they had cancelled her cycle about 6 times because endometrium would never get more than 5. So, you know, she was having some immune things which were helping her with here. So I did a scan on a Saturday and it was still the same, 4.8. I told her, look, have they tried giving some Nipogen flush? He said, no, they haven't done it. I said, well, you know, you can't keep canceling this cycle. Why don't you try that and see what happens? And then she tried it. She came back. I scanned her. It was now about 6. I told him, look, you can't keep, her embryos are there. You can't keep postponing it. I'll go ahead with the treatment. She got pregnant and had a baby. We had another lady who came through quite recently. Long history. I mean, there's nothing we didn't do. We checked for adhesion. She had a hysteroscopy twice. We checked for chronic endometrial infection. We did all the stuff, the Alice, Emma. We even did the hidden seed test. Everything came back normal, and still the lining wasn't thick enough. So last time she came, I said, okay, let's look at the blood flow, because the bottom line when it comes to successful implantation is for the embryo to connect to the blood flow in the uterus. So I checked that and I was surprised, even though it was 4.8, very good blood flow in the endometrium. So I told her, look, let's go with it. We went with it. She's pregnant, and initially I was a bit concerned. I thought, well, I hope it just lasts. And she's pregnant, and she must be getting to 12 weeks now. So everything seems to be going really well. So I would rather have 6 millimeter with very good blood flow than have 10 millimeters, but with very poor blood flow, because the embryo
Yeah,
has to connect with this blood flow. So
yeah,
it's not you know, there's the magic of 8 millimeters. Everybody tend to aim at is somebody had a publication, looked at all the pregnancies in the clinic in America, and found that they were all 8 millimeters and above. So he said, oh no, okay, so they have to be 8 millimeters. But then a few years later, somebody went back to that same clinic and said, okay, how about people who didn't get pregnant? Guess what? Their endometrium was also 8 millimeters and above. So you can interpret it the way you want it. But
Yeah, and it makes women feel very negative, doesn't it? That they're not hitting this magic target of 10.
I'll look at other things,
Yeah.
I look at the
It's very
pattern,
good
I look
about
at
blood flow,
blood
definitely.
flow, and if sometimes we give Viagra to see if we can improve blood flow. The Viagra is for the woman, by the way, not the gentleman, and and to see if we can improve blood flow. And if we have a good enough blood flow and a good pattern, you can't keep postponing it. I think you can still get pregnant.
The last question here, George. I've been told it looks like I have a polyp that will that have stopped implantation? I've had 2 failed transfers. I also have endometriosis. Do I need any extra help with implantation?
Well, let's look at the polyps. Polyps, it's just almost like a skin tag, but in the uterus. So it could be sometimes when the lining grows very exuberantly, sometimes they buckle, and then you can see that. Sometimes it's just a tag that is there. Now, the endometrium, where the embryos can implant, is quite a lot. So polyp in itself it won't 100% stop implantation, because there'll be a lot of areas where the embryos can implant. So if the embryo falls in a different area, of course you can get pregnant. And then it depends on the size. So if it's a small polyp, that means that the areas where you can have implantation is much more, then it will have less impact. If it's a huge polyp occupying literally all the endometrium, then it has more impact. And what we say is, if it's during the treatment itself, I judge it to be quite small, I personally feel you can continue the treatment unless you want to stop and deal with it. But if you see it before you start, I think I would remove it.
Okay.
Because to get pregnant is hard enough. You don't want to add any more to it. Then about the endometriosis, it's a very interesting thing, the endometriosis. My experience with it is that, it seems to be, it's if you're trying to conceive naturally, then it seems to there is an association between endometriosis and unexplained infertility. It seems to be more difficult to get pregnant, and there are all sorts of theories about that. My experience is that in IVF, it doesn't seem to have the same. I wonder whether it's because you take the eggs out of the system, fertilize them, and just put them back later on. So maybe that's why the impact is not quite as much. Now, when it affects egg quality, again, it's not a given. If you get eggs from anyone, you will have good embryos, poor embryos. It doesn't matter how bad endometriosis is. If you get eggs, they fertilize and give you good quality embryos, I think the pregnancy rate is going to be quite good. So I don't think there's any particular. Some Americans are saying what you should do is suppress, give these depot injections that will stop the periods for 3 months, then start the treatment. The evidence is very poor on that because we don't do that, and yet the results are very good.
Yeah. Somebody's just asking here, do we measure the blood flow through a doppler at the clinic?
Yes, all our ultrasound scans have dopplers. It's not something. It's not like measuring the giving the figures. If you put a doppler on the lining, you can see the flows. You can see it.
Yeah.
And in fact, Jeff Scher in America all those years ago did a study that actually showed clearly that blood flow. If you have poor blood flow, which he defined, you can see, if you put a Doppler, you can see the red spots, and he had a number. If it's less than so much number, then if it's less than that, pregnancy rates are very low. If it's above that, pregnancy rates are very good. So it's something you can do. It's quite simple, just in the normal scanning. Put the doppler on it, see whether there's good blood flow or not. If there is, then I would go along with it.
Okay, so George, we're coming to the end now. Is there any other sort of pearls of wisdom? You've been doing this for a long time. What do you think contributes to success? We've got all the fancy science and tests and investigation, but
I think
what are your thoughts?
it boils down to what I've learned over the years is preparation, the holistic approach. It's such a given that if you have the best quality egg and sperm, then you have a better chance of a successful pregnancy. I think that preparation, I think, is extremely important. And secondly, pay attention to detail.
Yeah.
Time to conception, all the little things you do, to improve the time to conception is very important. Body, mind, spirit, everything together in sync. And then pay attention to the details, the choice, personalize the treatment, get the right protocol for every individual, not because they're a certain age. If you do all those things, personalize the treatment, pay attention, micromanage it if you can, make sure that the embryo transfer is as good as it can be. If you have all these areas, so before treatment, during treatment, after treatment, enough support, then of course you will optimize your chances. Time to conception is a new buzzword. Time to conception means clinicians should do a lot before to make sure that people get pregnant more quickly. It saves them time, it saves them money, it saves them any psychological upheavals.
Okay, fantastic. George, thank you so much for coming on. I've got through half the questions, but I'd love you to come back on in a couple of weeks' time to go through some more.
I would love to come back on, Zita. You know that. I would love to come back again.
Okay, fantastic. Okay, so on Wednesday, tomorrow evening, I've got James Hemsley, who is a coach and does a lot to support men. So he'll be telling his story. So thank you all for listening this evening, and I'll see you tomorrow evening. Okay, this will be recorded, so you'll be able to see it. Okay, George.
Okay, bye everyone.
I'll speak to you soon. Say goodbye to everybody.
Every luck with your treatments.
Okay, bye.
Bye.